everyone, and welcome back to the journey. As you can see, today we're going to be talking about Cushing Syndrome. Now, with Cushing Syndrome, it's pretty much an excessive amount of adrenal cortical activity as well as a hyperactivity of adrenal cortex that leads to an increase in glucocorticoids, particularly cortisols. Okay. Now, with this, women ages between 20 to 40 years of age are 5 times more likely to exhibit Cushing Syndrome than men. Okay, so that lets you know you're going to see more women with this problem than men. Okay, now with this said, I always like to compare Cushing syndrome with Addison's disease. Now, if you guys want more information about Addison's disease, please feel free to check out my video on that. And I always say that it's good to study these two side by side because I call them the disease twins. Okay, and what I mean by that is they're literally mirrors each other. Okay, like when you stand in the mirror, when you lift up your right hand and the mirror itself is actually the left hand. So this is pretty much the same concept. Cushing's and Addison's, they're like the complete opposite of each other, right? Especially when it comes down to the signs and symptoms. So when I get to that, please pay very close attention. If you don't get anything else, pay very close attention. And also, if you want to know more about the adrenal gland itself, you can also check out the Addison's disease YouTube as well, YouTube video, just because I kind of go more in depth of how the adrenal gland works. Okay, so if you guys want a better understanding, please check out that video. Now, the causes of Cushing syndrome. Now, with it is pretty much a use of corticosteroids medication. So the fact that you use a lot of it, right? I have an excessive amount. That makes sense. Also, if I have a tumor on the pituitary gland that produces ACTH and stimulates the adrenal cortex, right? So I have a tumor that is secreting more and more and more than what is needed, right? Which you don't want that. Also, I have hyperplasia of the adrenal cortex, right? And I have eventually normal function is going to be lost. We have our clinical manifestation, which is also known as our signs and symptoms, which is also known as our nursing assessment. So with Cushing syndrome, right, remember we have an oversecretion of glucocorticoids, right, as well as androgen, which are our sex hormones, okay? Androgen is mainly for the male hormones, right? Estrogen is mainly for the female, right? But we do have some of the male hormones, but in this case we have an overproduction of those sex hormones and some of the mineral corticoids, okay? And I say this because when I get to the rest of this, you'll start to see and put together, aha, now I see why they're exhibiting these signs and symptoms, okay? So just keep that in mind. So the first up we have is our osteoporosis. In females, we're mainly going to see most of the osteoporosis. This may be an early onset of it. And again, you may also have kyphosis. And kyphosis is pretty much a concave back, okay? So it's almost like the hunchback, like you've ever seen that movie, The Hunchback of Notre Dame, right? So pretty much hunchback, that's your kyphosis, okay? And you may have back aches, okay? Another thing you may exhibit is your general muscle wasting, right? Or weakness, or arrest of growth, which pretty much means a stop of your growth, okay? So definitely your muscles are going to play a part. Generalized weakness, muscle wasting, okay? Moon face, okay? Moon face. And when I exaggerate on something or I emphasize on something, it is because that is a test question, okay? Patient comes in with a moon face. What is that a sign of? What does she have? Cushing's, okay? Cushing's syndrome. So moon face, the buffalo hump, right? Remember the hump? We just talked about it with the kyphosis. We have that buffalo hump. With the buffalo hump, right? We have this area, the neck area is going to be very meaty, okay? Very fatty. So I have the buffalo hump in the neck and also in my supraclavicular areas here, okay? I'm gonna have like my little, what you call like fat pads. So those football players, when they have those pads, right, that helps protect them, just think of that as fat. So this whole area, right, makes that buffalo hump. Also, you have truncal obesity. So the trunk area mainly is going to be very, very big, okay? Trunk obesity with thin extremities. My extremities are thin, truncal obesity. Weight gain, whereas with Addison's, we had weight loss, okay? Hirsutism, which is pretty much male characteristics because of our increase in sex hormones. So in females, they're going to have male characteristics where they may have an actual beard, facial hair, right? You might probably say, oh, there's some women that like that now. That doesn't mean that they have Cushing syndrome, okay? So those of you guys who are probably thinking or going at that point, right? We're talking about women who did not have facial hair and all of a sudden now have these facial hairs, has the moon shape, has the truncal obesity, right? You don't just look at one thing and say, oh, yep, this person has Cushing's, right? As much as you want to make it as a joke, you also want to see, you know, multiple signs and symptoms, not just one thing. That doesn't mean that they have Cushing's. So that's another thing because of our sex hormones. We also have hyperglycemia, whereas in Addison's we have hypoglycemia, right? Now with the hyperglycemia, it can lead the patient to have diabetes, and with that you're going to have the signs and symptoms of a diabetic, which you're going to have the slow healing process because that's one of the signs and symptoms with diabetes. So don't be alarmed if you start to see that this patient also starts to exhibit signs of diabetes because they have hyperglycemia. They also have hypernatremia, high sodium, whereas in Addison's we have a low sodium, right? Hyponatremia. We have with Cushing's hypokalemia, whereas in Addison's we have hyperkalemia, okay? With Cushing's we have hypocalcemia, right? We have low calcium, and we have hypertension, right? High blood pressure, whereas in Addison's we have a low blood pressure. So you see what I said? These are like the disease twins because they literally reflect each other in opposite ways, okay? So just remember Cushing's, right? Cushing, you have a Cushing, right? Truncal obesity, the buffalo hump, the supraclavicular pads, right? It puts on Cushing. So think of you putting on Cushing, right? Right? Meat on you. Whereas Addison's, we need to add because you have lost, right? You're skinny, weight loss, you don't have anything. You need to add for Addison's. Cushing's, we're like stuff, like a pillow, okay? So if that helps in any kind of way whatsoever to help you to remember the difference between Cushing's and Addison's, think about it in that sense, okay? But definitely, I know I'm probably sounding like a person who, you know, doesn't know how to speak or so, but I'm really stressing this because, again, these are things that you see on your test questions over and over and over. The difference between Cushing's and Addison's. And when a patient comes in with the moon face and truncal obesity, with thin extremities, you know, buffalo hump, think Cushing's. When they say patient comes in weight loss, hyperglycemia, hyponatremia, low blood pressure, Addisonian crisis, think Addison. Okay? So hopefully that helps as I'm stressing these things. Hopefully it clicks and you get that aha moment, okay? So with oversecretion of glucocorticoids, right? What glucocorticoid sounds like what? Glucose. So therefore I have my increased glucose. So just try to pick out as you're studying things that will help incorporate to memory exactly what is happening with this disease process. Try to pull everything that you possibly can, and once you understand the concept, you don't have to worry about memorizing every little thing, right? Because you have the concept. The concept is there, which can explain why are you seeing this, why are you seeing that, whereas just memorizing and not knowing the concept. To continue on with the clinical manifestations of Cushing, we also have fragile skin that is easily broken or able to bruise. You also have reddish purplish striae on the abdomen as well as the upper thighs, okay? So that is a key thing when it comes to Cushing's to kind of help you understand. Patient comes in, they're able to bruise easily, they have striation on the abdomen and upper thigh, they have the moon face, buffalo hump. Think about all these things, okay? They also can have heart failure. Libido is lost in both men and women, and libido is pretty much your sex drive, Okay, virilization in women mainly is going to be affected by this because your breast starts to atrophy, so it starts to shrink in size, right? That's like every woman's nightmare, right? You don't want that to happen at all. All right, your menses stop. That's something that's not bad, right? We don't really care for our menses, but in this case, you don't want that because then you're gonna go into what? Early menopause, and you don't want that. Okay. The clitoris enlarges, okay, as well as your voice deepens, okay. So in women, these are all negative things that you don't want to happen to you. So again, those are key factors that can kind of trigger to let someone know, hey, you know, this wasn't like this before. You know, I had a high-pitched voice, I had breasts, I had my menstruation, you know, I didn't have any facial hair, and all of a sudden now my voice is getting deeper, I'm having the facial hair, all these different things, especially if you never had it before, those are definitely red signs, red flags. And also visual changes in tumor if you have the pituitary gland. Now we have the diagnostic testing for Cushing syndrome. Now with Cushing syndrome, you have multiple things that you can do. First up is they may want to try an overnight dexamethasone suppression, all right? And that test is pretty much they're going to give 1 milligram administered around 11 p.m. at night, and a plasma cortisol level is going to be obtained at 8 a.m. The suppression of the cortisol that is less than 5 is considered a normal finding, right? So that means that it's functioning properly. Anything more than 5 can indicate that, hey, the body is producing so much, you know, that it's not able to suppress it to a level of where it can properly function. Okay, so that's one test that they can do. Another test that they can do is the nighttime salivary cortisol level, and that's pretty much the same as the overnight dexamethasone. The only thing is that it's going to be different intervals of the dosage as well as the time throughout the night. So they may change the ranges. You know, the dose may increase or decrease, and it may not be at 11. It may be later. It may be sooner. So it all fluctuate, and that's the nighttime salivary cortisol level. Another thing that they can check is your lab results, right? You remember you're going to have an increase of your sodium, an increase in your blood glucose, a decrease in your potassium, and a decrease in your white blood cell, okay? Whereas in adolescents, you have a decrease in sodium, a decrease in blood glucose, an increase in potassium, and an increase in your white blood cell, okay? So again, it mirrors each other where it's like the complete opposite, okay? Urinary cortisol levels is another test that they can do to see if the patient has Cushing syndrome, as well as a measurement of the plasma of the ACTH by radial immunoassay. And last but not least, you can always do a CT, ultrasound, or MRI, and that is to detect to see if there is any tumors, right? Whether there's one on the adrenal gland itself or in the pituitary gland. Now we have our medical management of Cushing syndrome. So if it's a pituitary problem where it's a tumor, right, we're going to have a surgical removal by a transphenoidal hypophysectomy. All right, so the transphenoidal is just the approach of what they're taking, and this pretty much transphenoidal is pretty much, you have behind you have a phenoid bone, and that's pretty much the approach that they're going to go. And of course, they're going to remove it. All right, it is an 80% success rate. So again, it's not a complete thing that, you know, once it's done, it's over, because you always have that 20%. But of course, 80% is always better than 20%. So that's an approach that the doctors may want to look at. Also, you have adrenalectomy for adrenal hypertrophy. So if the adrenal gland itself is the problem, if it's being enlarged, if you know that's where the damage is occurring, they may just go ahead and just remove the adrenal gland completely. And of course, with that, you're going to need lifelong treatment of your corticosteroids, because again, your body still needs those hormones. You went from having so much to now having absolutely nothing, okay? That can definitely shock your body and put your body in a state of Addisonian crisis, okay? So if you guys want more information about Addisonian crisis, you can also look out for my video for Addisonian disease. But a quick little overview is pretty much a crisis that's going to cause a complication of where you're in shock, okay? Your body is in complete shock because it went from so much to now having nothing at all. Your body is in Addisonian crisis. You have a low blood pressure. Heart rate may be low, maybe tachycardic. Your respiration is going to be rapid, right? Weak pulse or, thready pulse. Just a complication you try to avoid when you have Addison's disease. So in Cushing's, you can go from having a lot to having absolutely nothing based on the intervention that they do. So if they do, think about the signs and symptoms of Addison's. So Addison's could overlap into Cushing's if you do not have enough of the hormones, okay? Radiation is another thing, right? Maybe the tumor can't be completely eradicated and they're not able to, or you may not want to do surgery, right? The patient have that right to say, I don't want to have surgery. What other possible interventions are there, right? We can do radiation. Also, you can have temporary hydrocortisone needed after the pituitary is removed for several months. So sometimes the adrenal is not the problem, it's the pituitary. We're going to remove the tumor from the pituitary, and with that said, you're going to need supplemental medications in the meantime, because your body has been so used to producing so much because of the tumor that now that the tumor is gone, the body still may need adjustment or aid to help them so that way they can get back to a normal state. So you may see this patient temporarily on it up until the body is able to regenerate and say, you know what, okay, I see what's going on here. All right, we don't have that influx that we had before. We need to get up and start making our own. And that can take over several months, okay? Also, adrenal enzyme inhibitors, right? Let's say surgery is not an option. We're just, wherever the tumor is, it's in a completely difficult spot. We can't move it. If so, we cause other potential problems to occur that is not suitable for the patient, right? So surgery is just not an option. Radiation just can't do or eradicate all of it, right? So now we're at a point where we want to decrease the amount of hormones that are coming out because we don't need our adrenaline to be hyper-stimulated. So what are we going to do? Adrenal enzyme inhibitors. So these are enzymes that is going to block, right, this pathway or this stimulation from occurring. So these are the different types of medication that you have, and what it does, it reduces the hyperadrenalism if the tumor cannot be removed, okay? So that's just another medication that they can use to kind of decrease the amount of hormone that is going to the adrenal gland. Also, you have a decrease in your corticosteroids, okay? So you may want to taper them off because they can cause your body to be put into shock, okay? And you may want to alternate the therapy. So what I mean by that is when you have a patient, right, let's say they're on temporary hydrocortisone, and remember all your corticosteroids, they end in zone, prednisone, hydrocortisone, any of those that ends in zone, those are your corticosteroids. So that's just a dead giveaway. If you hear that, we're talking about a steroid. Now, let's say they have to be on it temporarily until the body is able to function and do what it has to do. Once you are at that moment where you're going to, stop the medication or cease it, you can never, ever, ever stop steroids abruptly. You just cannot, okay? So I'm going to say this again. Do you stop steroids abruptly? The answer is no, okay? And that's most likely a question that you may see on your nursing exam, right? What are you going to do? You're going to taper it off. What taper means is pretty much, let's say for corticosteroids, you was getting 5 the first day, right? The next day you may get 4. The next day you may get 3. The next day 2, 1, and then slowly you're off of it, okay? And that's exactly how they work. You're never supposed to stop abruptly. And this is the reason why, okay? Because when you have the concept, you kind of remember it a little bit better, okay? So you have your corticosteroids, and your body is used to producing it, right? The minute you have medication, the body says, hey, we don't need to make corticosteroids because for some reason we got corticosteroids today. Don't know how, but hey, don't go to work, you guys, because we're getting it. The next day, same thing. Hey, we're still getting it. Let's go on break. The next day, same thing. Same thing, same thing, same thing. Right? So eventually the body just kind of chills and say, well, I'm going to put my feet up because we're not making any corticosteroids because somehow, some way, we're getting them. So boys, don't worry about it. Relax. We're on vacation, right? Do not disturb. All of a sudden, you just stop the steroids and you say, okay, body, I want you to go start working again. They've been on vacation because somehow you've been getting it. They don't know how, but they don't care. They've been on break. And all of a sudden you stop. There is no corticosteroids because no one ever said, hey, I'm giving you my 2-week notice. I'm leaving and I need you to come back to work. That does not happen. So you didn't get your corticosteroids because you stopped. And then you didn't give your body enough time to say, hey, what's going on? We have not received. So what happens is there is none, or a very, very, very low amount, right? And the body is like, oh my gosh, we have to go in overdrive because, you know, there is no corticosteroid and we have to wake back up, get everybody on board. Come on, let's go ahead and make it. And by that time, your body would have gone through so much that it puts your body in a shock. Therefore, you get the Addisonian crisis, which is the very thing that you try to prevent. So when it comes to corticosteroids and you have to stop them or cease them, you never stop abruptly. You taper them off, all right? 5, 4, 3, 2, 1. So that way it tells your body, hey, we got some corticosteroids today, but we didn't get enough of what we needed. So hey, we need to make some. So they make that supplement amount. The next day, realize, hey, we were already short 1, now we're short 2. Hey, we need to make more. The next day, hey, we were short, now we're short 3. Hey, we need to wake up and make more. Till finally your body says, all right, I'm going to make because I can't rely on this other one because they're not there. And that's how you put your body back in a cycle of making the hormones that the body needs so that way it can function properly and avoid complications. So I hope that helps. I know it can be a little weird or strange or funny how I use examples, but they always help. They work. Just remember the concept, right? And once you get that, you understand why we need to taper. And you will never get that question wrong on a nursing exam. You taper, you taper. Not just in Cushing's, not just in you know, adrenal complications. Any steroids that you're going to give, you always taper them off. Always. And last but not least, we have our nursing interventions. Now, with our nursing interventions, we want to make sure that we decrease the risk of injury. So we want to avoid falls, any sharp objects, because remember, if these patients have diabetes or have high glucose, right, we have a poor healing process or slow healing. So you want to make sure that, you know, there's blunt objects around them, things like that. They're looking and seeing what's going on. Also, you want to monitor their diet, okay? Another thing, you want to decrease the risk of infection, okay? Another thing, when it comes to corticosteroids, they kind of work as an immunosuppressant just because they are anti-inflammatory medication. So they kind of hide the inflammatory response, which is your natural way of your body protecting itself and alerting you, letting you know, hey, what's going on? And they're fighting against that infection. Right? When you have an anti-inflammatory, you block that mechanism from happening, so you're more susceptible to having infection. So you want to decrease the risk of that. Okay? Also, preparing for surgery. If the patient is going for surgery, you want to make sure that you're prepping them, you're giving them antibiotics, that they're clean, that you have the consents that you need, that they fully understand, that the surgeon has explained and said everything that is needed. You know, want to just have that checklist. You know, if they have a Foley, are they going to need a Foley? Make sure you have your IV access, things like that. Another thing, if they are going for surgery because of the pituitary tumor, one thing that you may see additionally to the signs and symptoms is changes with the vision, right? Problem with vision is because of where the tumor is pressing down on the pituitary. It's very close to the optic chiasm and the nerve and everything. So that's another thing that could be affected. So they may tell you, hey, I'm having problems seeing, or, you know, something is not right. I'm having blurry vision. So that's another thing you want to kind of look out for if the patient does have a pituitary tumor, okay? But definitely prep them for surgery. Another thing, you want to encourage rest and activity. Promote skin integrity. Make sure that the skin stays intact. improving body image and thought process. Because remember, especially when it comes to females, you know, one day you wake up and, you know, you saw yourself as a beautiful woman, and the next day you see yourself as a man, and you're like, you know, what is going on? I'm having facial hair, my breasts are shrinking, I don't have my menstruation anymore. You know, all these different things kind of play a part in a woman's mind. You know, sometimes, you know, not having certain aspects, you may think that you're not a woman because you don't have certain aspects that society tells you that you have to have, you know, womanly characteristics. So that's another thing that you want to be there for them about, you know, support groups, definitely listening to them, hearing their disagreements about themselves, and just kind of encouraging them along the way and letting them know that, you know, there are help out there, support groups and things like that. And sometimes just hearing another woman's story can definitely empower another woman. Okay. And also, last but not least, we have our monitoring and managing potential complication. That potential complication that we're trying to avoid is our Andersonian crisis. So again, you definitely want to avoid that from happening, because you don't want to have a low blood pressure, low heart rate, right? This is the time where you definitely want to call the doctor if you start to see that there's a risk of. You definitely want to speak up about it, let someone know. Don't keep it to yourself. Always go off of your consciousness, you know. Something's telling you, man, it doesn't feel right. You know, I think this person is not okay. You know, I rather call and it be a false alarm than it not being a false alarm and there's nothing that we can do about it now. Okay, so you definitely want to prevent that from occurring. Monitor those vital signs, monitor the patient, listen to what the patient is telling you. All right. And that is pretty much it with Cushing syndrome. If you like this video, go ahead and give it a thumbs up. If you have any questions or comments, please feel free to leave it in the comment sections below. If you want to see more added information, also check out my description box. And again, if you have not subscribed yet, what are you waiting for? Go ahead and click that subscribe button. If you want to follow me on Instagram, I also have the link that will be provided in the description box. And again, thanks for coming on this journey. I'll see you on the next one. Bye.